Thank you for following along this entire course on mastering endodontic diagnosis on this YouTube playlist. Check out all other videos in this playlist. Right now, let's jump into pulpal diagnosis. Just as we said earlier, there is a pulpal part of the diagnosis and there is a periapical or periradicular part to the diagnosis. So you have to always separately make a pulpal diagnosis, which is going to be completely independent of the periapical diagnosis or the periodontal or periradicular diagnosis that you will make for that particular tooth, and vice versa. So these are two different things, and you will always mention both, that my pulpal diagnosis is that the pulp is vital, inflamed, irreversible pulpitis, reversible pulpitis, early stage, late stage, or anything like that. And then you will also say that my periradicular or periapical diagnosis is that the tooth also has some symptomatic periapical periodontitis or asymptomatic periapical periodontitis or chronic periapical abscess or acute periapical abscess. These are a bunch of tongue twisters, but that's what you are trying to find out when you are confirming a diagnosis of the tooth. What is the pulpal status and what is the periradicular status? I hope that's clear. Let's talk about pulpal diagnosis. Either the pulp is going to be normal, which is healthy tooth, any tooth, the control tooth or the contralateral tooth or the adjacent tooth, they all will have normal pulp, and that's how you will keep it as a baseline to evaluate response for the offending tooth. Now the offending tooth can have a reversible pulpitis, or they can have an asymptomatic irreversible pulpitis. There the inflammation is irreversible, but the patient is still asymptomatic there. Or they can have a symptomatic irreversible pulpitis, which is when patients see you most of the time. Other than that, it can be a dead pulp or a necrosed pulp. So that is another diagnosis. And lastly, it's a very important diagnosis, previously treated RCT or previously initiated RCT treated tooth, because sometimes we just cannot account for it, or the patient may not even give you the full history, or you look at the radiograph, you're like, oh, looks like somebody started a root canal treatment and never completed it. Now this is different than a necrosed pulp. Here the pulp is removed, or the treatment was started, or some kind of treatment was done. And on the other hand, if the patient has never got any treatment done on this and pulp is necrosed, there is some kind of excess pathology in there. So these are two different things, right? But they both will give you a negative response or a negative response on the EPT or 80 reading on EPT. But they both are two different things. I hope that's clear. So that's about the pulpal diagnosis. Now I'm going to create one big table, and I will try to explain you all these pulpal diagnoses using one table. And I'm sure that by end of that one video, one lecture, you will know how to correctly answer any question which will trick you between reversible or irreversible pulpitis, asymptomatic or symptomatic irreversible pulpitis, or necrosis. All those things will be covered in the next video. Let's check that out. Alright, so here is my big table. On the left side of the column, I have given you normal pulp, reversible pulpitis, irreversible pulpitis early stage, irreversible pulpitis late stage, also known as acute suppurative pulpitis. Now this name is completely gone. Acute suppurative pulpitis is not even part of the real classification anymore. So is early stage and late stage, gone. But some of the question in national board exams as well as NEET exam and other competitive exams, they always have those one or two historical questions that still linger around. So you need to know the old terminology as well, and you also need to know the new terminology, because most of the questions will ask you new terminology, but some of those weird odd ones will show up, which will give you one of the option, acute suppurative pulpitis. There will be many other options like polyp has some other names, and there are multiple other old names that I'll mention here, so you have to keep a note of them here for your competitive exams or for your national board exams, because they will ask you questions like this. There will be some questions like this. So once again, irreversible pulpitis late stage is known as acute suppurative pulpitis, while irreversible pulpitis early stage is known as irreversible pulpitis only. Asymptomatic irreversible pulpitis is also known as or it cannot necessarily be, but it is also known as hyperplastic pulpitis, pulp polyp, chronic proliferative infection, pulpitis or chronic ulcerative pulpitis. Chronic proliferative pulpitis or chronic ulcerative pulpitis. Then next one would be a pulp necrosis. So let's dive into each one of these. What are some of the things that we are going to compare all these different classifications of pulpal status on? So we will try to compare them on spontaneous pain, pain to cold, which is going to be our old school cold test, pain to heat, which is going to be our heat test, EPT, what is the EPT reading they give, tenderness to percussion, palpation, mobility, probing, which are our periodontal test, and PDL on the radiograph. How do you see these on radiograph? What kind of signs they show you on the radiographs, and what is the possible treatment option? Because hey, of course we are going to do a treatment for any of the pulpal condition because patient is in pain, patient needs some treatment, right? So let's run into the first one, which is normal pulp. So in normal pulp, are you going to see any spontaneous pain? The answer is no, there will be no spontaneous pain. Are you going to see pain to the cold? Actually, it's going to be normal. If you give anyone too cold thing, they might give you a little pain, but it will be all around same in every single tooth. So it's going to be normal. Pain to heat is going to be normal. And EPT reading, as I have been saying again and again in this course, is going to be between 1 to 79. Tenderness to percussion, there is going to be no response. Palpation, no response at all. Mobility, not acceptable. It could be because of perio reason, but it will not be because of any endodontic reason. Probing will not be due to any endodontic reason. It could be because of any restoration or any periodontal condition occurring. The radiograph will show normal PDL and there is no treatment needed for a normal tooth. Now let's come to the main things. Reversible pulpitis. Do you see a patient with a spontaneous pain when they have a reversible pulpitis? No. If you injure the pulp a little bit, it has capacity, it has inherent capacity to heal itself. It is going to get better soon. It is just for some reason right now it is inflamed, but it has potential to heal itself and it will be comfortable soon. Just give the patient some ibuprofen to take at home for a few days and they will be okay. So how do you know that it's a reversible pulpitis? You don't have to put them into a root canal treatment for a reversible pulpitis. So the patient is definitely not going to say spontaneous pain. The pain only comes for a very small time, only when we give them certain stimulus. If you do a cold test on that patient, they will feel the pain, but for a very short amount of time. So you always say that yes, short pain. It's not a lingering pain. It's not a long-standing pain. It's a short pain. That means reversible pulpitis. Pain to heat. Again, if you do a heat test, that they will have a very short amount of short duration of pain. So that is again pain due to heat. After that, if you do EPT, it's still a vital pulp. So you are going to get an EPT between 1 to 79. It will never be 80. If you do a percussion test, you might not get a good response because the periodontal status is not compromised. If it's only the pulpal problem, then the periodontium is completely healthy, then you will not get any response to the tenderness to percussion. Palpation will not give you any response. Mobility and probing is not relevant. Even if it is there, then that may be because of the periodontal condition, not because of the endodontic diagnosis. What do you see on radiograph? You see completely normal PDL, no need to worry, everything is good. Then do you need to give any treatment? Answer is no, no treatment for this patient. So that was all about reversible pulpitis. See, I don't want to give you any slide with lots of bullets and describing characteristic about it. This one table can give you like every information that you need to answer any question that will show up in your competitive exams or in your national board exams related to pulpal conditions. So let's jump into the next one, which is irreversible pulpitis, and I'm giving you this one for early stage. So when it's an early stage irreversible pulpitis, I'm not saying it is, but it is symptomatic, but it's early stage. Symptomatic, but early stage. Then you will get spontaneous pain. Yes, because it's irreversible pulpitis. That's a characteristic of irreversible pulpitis, that the patient has spontaneous pain. If there was no spontaneous pain, either it's reversible pulpitis or the pulp necrosis. I hope that's clear. Spontaneous pain means irreversible pulpitis. This is early stage. If you do a cold test, if you apply cold, yes, the pain is sharp and it's lingering. It stays for some time. That means it's irreversible pulpitis. If it resolves itself within a few seconds, it was reversible pulpitis, right? But here it's sharp and lingering. That means it is irreversible pulpitis. If you give a heat test, or how is the pain to heat, then yes, there is pain to heat and it's prolonged because it's early stage. Remember this, I will come back to it. In early stage, there is prolonged pain to heat. If you do the EPT, you will get a reading from 1 to 79 showing it's a vital pulp. Tenderness to percussion has no response. Palpation has no response. Mobility and probing is irrelevant because it's only pulpal condition. It does not have to do anything with the periapical area. Then PDL is going to be normal. In reversible pulpitis, you should not see anything in the PDL widening. So do not confuse those two things. If there is a PDL widening, then you are coming to the periapical diagnosis later. For this time, stick with the pulpal status. Pulpal status, are you going to see anything on the radiograph? No. So answer is none. What is the treatment for it? Now the treatment is a non-surgical root canal treatment or extraction, or give them analgesic for some time, which is NSAIDs, and ask them to come back tomorrow to do their root canal treatment. Eventually, they have to do the root canal treatment. Take the pulp out or take the tooth out. So that was the early stage irreversible pulpitis. This is the old terminology. We don't use it anymore, but in exams, they give you this option to just freak you out. So it's given right here. What is early stage pulpitis? Early stage irreversible pulpitis. Now let's go to the late stage irreversible pulpitis. And these both are symptomatic irreversible pulpitis because the patient has pain. There is a symptom. That means it's symptomatic, irreversible pulpitis, late stage. Yes, there is a throbbing pain. The patient cannot sleep in the night, or there is so much pain that the patient wakes up in the night. That's like super, super high pain. That's when the patient in the morning, first emergency appointment is patient like this, and they want you to treat them right away. So those are the cases with irreversible pulpitis in late stage, also known as acute suppurative pulpitis. Earlier, acute was a common terminology used for pulpitis as well and chronic, but they have taken it out. Now it's symptomatic and asymptomatic irreversible or reversible pulpitis now. So yes, there is a throbbing pain which wakes the patient up at night, late stage. Next is pain due to cold test. No, that patient which has extreme pain, which was awake all night, will actually find that if they keep some ice here, then they feel some relief. So pain is not caused by the cold test. Pain is actually relieved by ice. Pain is relieved by cold. Classic, super important for a late stage irreversible pulpitis, symptomatic irreversible pulpitis, that the pain is relieved by cold. I hope you got that one somewhere with a star sign. And next is, what about the pain due to heat? So you would say, yes, there is a pain which is due to heat, but then again, it is relieved by applying cold. So if the patient drinks hot coffee, they feel extreme pain, but then when they apply some cold or some ice pack, then they feel relieved. So that's a classic of symptomatic irreversible pulpitis late stage. I'm being repetitive, but I want you to leave this video with a complete condensed memory of this whole diagnosis. EPT, it's still vital. It's just inflammation. It's a irreversible pulpitis, so it's vital. EPT is going to be 1 to 79, no matter how much pain the patient has. Tenderness to percussion may or may not be, because by this time there may be some periradicular inflammation already. So just ignore tender to percussion whenever you are thinking about pulpal status. That's why I've given it there, so that I keep repeating this thing, that if it's there, it's not due to the pulpal origin. It is because along with the late stage irreversible pulpitis, you will see some periapical, periradicular periodontitis. So that's why there may be some pain. So we don't know what is the origin of that pain. Palpation may or may not be. We are not sure yet. Mobility, absolutely, if it is there, then it's definitely due to the periodontal diagnosis. Same as probing. PDL on the radiograph. So this is the first time where you may or may not see some signs of the PDL widening on the radiograph. Again, we cannot 100% say that the pulpitis, the irreversible pulpitis, has caused periodontium to be like there. It can cause PDL widening. It's not common to see, but there is something called a crossover phenomenon. So what is a crossover phenomenon? You do not want to get too much in depth of it. It is absolutely useless. There are some tons of studies on it where somebody has described this crossover phenomenon, which may result in PDL appearance during the late stage irreversible pulpitis symptomatic origin, and you do not have to worry about it. Just know that there may or may not be any signs of pedial widening on the radiograph during the late stage symptomatic irreversible pulpitis. And treatment is going to be root canal treatment. It's going to be an emergency root canal treatment. You will do at least a favor to the patient by doing an access opening during that appointment only. And after that comes asymptomatic irreversible pulpitis. Now it is completely different from polyp, but I'm keeping that here because they both will show the same kind of signs and symptoms and same kind of finding when going for a diagnosis. So asymptomatic irreversible pulpitis is when there is irreversible pulpitis. The pulp is inflamed, but it is not giving you any symptoms of pain due to cold or heat or anything else. Pulp polyp is a response to a chronic inflammation of the pulp, and it has many other names which include hyperplastic pulpitis, pulp polyp, chronic proliferative pulpitis, or chronic ulcerative pulpitis. For those as well as for asymptomatic irreversible pulpitis, you will not see spontaneous pain. There will be no spontaneous pain. What about with cold test or pain due to cold? It's going to be normal, just like any normal tooth. What about heat test or pain due to heat? It's going to be normal. Remember the keyword asymptomatic. Patient does not have symptoms on that specific tooth, so it's asymptomatic. EPT is going to give you 1 to 79 because it is definitely vital. Nothing is dead in that tooth. Would you see tenderness to percussion? We are not sure. Even if it is due to the periapical diagnosis, not because of the pulpal diagnosis. So is palpation, mobility, probing, anything on the radiograph, none of that is going to be related to the asymptomatic irreversible pulpitis. Treatment, you are not sure yet. I have put a cross there because we don't know the treatment yet. We have to find out more about this certain case that first of all, why are we even doing test on this tooth? It could be due to being the adjacent tooth, and we were considering it as a baseline, but now we are accidentally finding that this may have some asymptomatic irreversible pulpitis. We think it's normal, but it does have irreversible pulpitis, so asymptomatic irreversible pulpitis. I hope I'm making a little bit sense here for those who are always confused between these concepts. Last is pulp necrosis. Pulp necrosis, you will not see a spontaneous pain. You will not see pain to cold. You will not see pain to heat. You will not see any response to the EPT. Some EPTs may only give you response yes or no or some kind of numbers. The one that we use at Dalhousie University has 1 to 80. 1 to 79 is vital, but 80 or no response means EPT is showing that the pulp is necrosed. So in pulp necrosis, EPT will give you no response or a reading of 80. Is there going to be a tenderness to percussion? Not because of the pulpal origin. None of these symptoms will be because of the pulpal origin, and the PDL is going to be normal, or it will show some signs due to the periradicular diagnosis, not because of the pulpal diagnosis. And treatment is always root canal treatment. So that was a quick summary of all possible endodontic lesions. I hope you will keep it somewhere in your brain, and if you draw this diagram again, this entire table, it's not too difficult. Just take a ruler on your pen and paper. If you use iPad, if you follow my course on digital note taking and you do everything on your OneNote or on a Microsoft Word or Excel, then just create a table out of it, type things down, and you will have this thing in your brain for a very long time. So just remember this chart and you are good with your pulpal diagnosis for good. Next one is going to be our favorite periapical diagnosis, which gives us tons of information for the patient's pain and condition. So this was just another video of the complete endodontic diagnosis series on my YouTube channel. So just go on the playlist section and follow along the entire playlist to master endodontic diagnosis for dentistry exams, which include national boards of USA, Canada, ADC, as well as NEET PG exams. And make sure you post in the comment section below if you have any questions around this topic. Subscribe to my channel, share this video with at least one friend.